Hello, my name is Cayla Pichan, and I am a third-year medical student at the University of Michigan. And I, with the help of an attending geriatric psychiatrist, created Get Access, Geriatric Education on Telehealth. With the onset of the COVID-19 pandemic, ambulatory care at the University of Michigan rapidly transitioned from in-person to virtual visits. While many patients were easily able to make this switch, geriatric patients were at a significant disadvantage due to their lack of access to and comfort with technology. Therefore, we created a program to respond to this particular need. The aim of the Get Access program was to facilitate the transition to virtual care, particularly video visits, as they have been shown to be a more effective means for delivering care compared to telephone-only visits. To do this, we created a well-organized training program for our volunteers to offer one-to-one remote guidance to help orient geriatric patients to the virtual platforms used for video visits. Our secondary goals were to share our findings with the larger healthcare system, while also ensuring the sustainability of the program beyond the immediate need of it due to COVID-19. I created a 28-page volunteer reference manual detailing the different video modalities and how to call patients using Doximity or Google Voice, as well as an algorithm and troubleshooting resources to allow the Get Access program to be self-sustaining. Virtual training sessions were held for our volunteers to walk them through the process and connect them with the faculty member that they would be working with for the duration of the project. We started working in the geriatric psychiatry clinic, and then, as we expanded our team to 26 total individuals, began servicing the geriatric general medicine clinics as well. We developed a three-call model to best serve our geriatric patients' range of technological capacity and access. During the initial call, the volunteer calls the patient 1 week in advance of their scheduled phone visit to gauge interest and discuss preferences and options for video visits. The volunteer, using the algorithm here, figures out which video software would be best based on the patient's comfort, limitations, and who needs to be present for the visit. Once a modality is chosen, the volunteers work creatively to guide the patient step by step through the process. At the end of the initial call, we set up a practice call to help the patient complete the electronic check-in process and practice the appointment using the video modality. Finally, after their visits, our volunteers call the patient for a third time to gather feedback on how the encounter went and if they were satisfied with the service. Over a 12-week evaluation period, 219 phone calls were made. The Get Access program volunteers were successful in teaching and converting over 88% of phone visits to video visits. Of all the visits made in the clinics we worked with, averaged over the 12-week evaluation period, visits after participation in our program was associated with video format 43% of the time, compared to 19% for visits prior to participation. It's important to note that these conversions occurred with patients who had been previously offered to switch to a video visit, but initially declined prior to our volunteers contacting them. In summary, the Get Access program was created and implemented by medical student volunteers as an initial immediate response to the abrupt transition to telehealth necessitated by the COVID-19 pandemic. Overall, we believe we were able to provide a stronger platform for providers to connect with their patients during this challenging time. Secondary benefits of this project that we explored were decreased social isolation as well as financial. So where do we go from here? The Get Access program will continue to be important as we transition into this next phase of the pandemic, both due to changing Medicare restrictions and new guidelines requiring older adults to be registered on patient portals to schedule their COVID-19 vaccination appointments. As such, we are currently working with Michigan Medicine Healthcare System leadership to expand our program beyond the geriatric psychiatry and general medicine clinics. With these planned expansions, we hope to be able to serve a greater portion of the community and increase financial reimbursements for physicians and the healthcare system as a whole. Thank you for your attention, and if you have any comments or feedback, we welcome them at getaccess@gmail.com. Thank you.